Good evening and welcome to the premiere of a new season of Doctors on Call. This is actually our 35th year. I'm Dr. Leif Christianson from the Department of Family Medicine and Community Health at the University of Minnesota Medical School here in Duluth. Tonight we're talking about heart problems and high blood pressure. So what would you like to know about controlling high blood pressure or the diagnosis, treatment, and prevention of heart attacks, heart disease, and heart failure? We're ready to take your questions at 218-788-2844 or toll free at 1-877-307-8762. And I do want to thank, before we start, Linda Liskowitz for the work that she's done in helping us make sure that we have our panel members and my other two hosts, Dr. Wester and Dr. Ellen Johns, as we make this program a reality for you each year. I'm pleased to welcome this evening's panelist, Dr. Kalkidan Bishu, a cardiologist with Essentia Health, St. Mary's Heart and Vascular Center, Dr. Leif Christianson, a cardiologist with St. Luke's Cardiology Associates, and Dr. John Wood, a physician at the Duluth Family Medicine Clinic and director of the Family Medicine Residency Program. Tonight, our medical students answering the phones for us are all Minnesota students. Carter Duncan hails from Kensington, Leif Olson from Pequot Lakes, and Sean Staffke is from Perham. And now, on to tonight's show about heart problems and blood pressure. Gentlemen, thank you very much for joining us this evening. I think it's really important for our listeners to have some idea what your backgrounds are. We have two new faces tonight. I appreciate that you both could join us. Dr. Bishu, could you tell us a little bit about your training and what you do?
Right. Thank you, Dr. Christensen. Thank you for having me here today. My name is Kalkidan Bishu. I work with Essentia Health, Heart and Vascular Institute here in Duluth. I am originally from Ethiopia. I went to medical school in Ethiopia, and I've done most of my training here in Minnesota. After that, I did my internal medicine residency at the University of Minnesota in Minneapolis, and my cardiology fellowship at the Mayo Clinic in Rochester, Minnesota. And then I went to Denver for 2 years to train in interventional coronary and structural interventions. And my wife and I liked Minnesota so much we decided to come back to Duluth, and I've just started a practice here with the Heart and Vascular Institute.
Great. Dr. Christensen.
Yes, hi, thanks for having me on. My name's Leif Christianson. I grew up in Fargo, North Dakota. I am an interventional cardiologist at St. Luke's Vascular and Heart Center. And I trained at the University of South Florida in Tampa. Just moved here about 2 months ago, and very happy to be in the area.
Dr. Wood, you've been around for a while, known you for a long time. Maybe you can tell us a little about yourself.
Yeah, Dr. Christensen, Ray, you and I go way back. John Wood. I'm currently the director of the Duluth Family Medicine Residency Program, which is training young family medicine physicians in order to be working out and delivering primary care to northern Minnesota and the rest of the United States and the world. I graduated from the University of Washington Medical School and did my residency here, and then worked in Grand Marais for a long time. I've worked in a lot of local ERs, moonlighting in different ERs around the northern part of our country. And currently, and as I said, involved with training residents, which is a great job. I love doing that, so it's been a lot of fun.
Well, welcome all three of you, and please start calling in your questions. We're going to start out this evening talking about hypertension. Dr. Wood, can you describe for us what hypertension is?
Sure. Start off, there's going to be a lot of numbers thrown out here because it's basically what it is. At first, it's a numbers game. It's incredibly common. It's probably 1 in 3 Americans, 80, 90 million people in the United States. A lot of people don't know they have hypertension. It's basically a silent disease, so you don't even know if you have it. Just to throw out more numbers, you've got, when you go to the physician's office, advanced care practitioner, the mall, you get a number, 120 over 80, 150 over 90, whatever it is. You're looking at two different numbers. One's the systolic number, or the number when the heart's contracting. The other is diastolic, where the heart's relaxing. So you get two different numbers. And then you break those numbers down further. 120 over 80 or less is good. 120 to say 139, or excuse me, 120 to 139 is sort of pre-hypertension. And 80 to 89 on that lower number is pre-hypertension. You get into over 140, over 90, you're talking high blood pressure. And 140 over to 159 is stage 1, and then everything over 160 is stage 2 hypertension. So a lot of numbers, but if you remember that number, 120 over 80 and then 140/90, you'll have a good way to start.
Dr. Christensen, there's the systolic and the diastolic portions of the blood pressure. Sometimes they're further apart, sometimes they're closer together, and the vascular system and the heart muscle are all parts of this. Maybe you and maybe even Dr. Bishu, could you address those components a little bit for us?
Sure. So the systolic blood pressure is essentially the blood pressure that the blood vessels are seeing when the heart is contracting and pumping blood out of the aorta into the rest of the body. The bottom number is essentially the pressure in the vessels when the heart is relaxing and filling with blood. And of course, this alternates with every cardiac cycle.
And like you pointed out, there is a gap between the 140 and 90, and that gap is what we call a pulse pressure. And I bring this up just because I think you might have been leading towards that when you brought up the question.
Mm-hmm.
The gap between the upper number, which is the systolic blood pressure, and the lower number, which is the diastolic blood pressure, changes as we age. People with stiffer blood vessels and long-term vascular disease tend to have a wider gap between the higher and the lower numbers. And that's because the higher numbers tends to be, the systolic blood pressure would be 120, 130, 140 as people develop hypertension. But with stiff blood pressures, the lower number, the diastolic blood pressure tends to be lower, 30, 40. So when the gap goes above 60, it's not just how high the two numbers are. The widening of the gap between the two numbers is also a marker of future cardiovascular events associated with a stiff blood vessel. Another thing I look at when I look at the gap between the two numbers is in people with a valvular heart disease. There tends to be a widening of the gap. If you have aortic insufficiency, a widening, how wide that gap gives you a sense of how bad the aortic insufficiency is, aortic valve insufficiency is. So the two things, that I wanted to add on.
Leif, one of the problems that I saw it in my dad.
Mm-hmm.
We tend to treat to 140/90 is kind of where we look to. With the elders and the hardening of the arteries and the stiffer arteries and so on, don't we have to be a little bit more careful with our blood pressures as people get older? I noticed that they've kind of done some equivocating and possibly changing where we should treat to. Do you have any comments on that?
Yeah, that's a difficult question.
I know.
And I believe the American Academy of Family Practitioners has some guidelines as to how to treat more elderly patients and what their goals of blood pressure should be. Because, as you mentioned, as the arteries harden, it tends to get harder and harder to control the blood pressure, and you end up putting more and more, you end up prescribing more and more blood pressure medications. And of course, the more you add, the more side effects that come with that. There was a trial put out last year called the SPRINT trial, which essentially showed that the more aggressive we are with blood pressure, the less cardiovascular events there are, meaning less heart attacks, less strokes, less kidney injury, less death. The flip side of that, though, was that the patients who were treated more aggressively, in other words, they had tried to achieve a lower blood pressure, had more complications in the sense that they had more fainting, they had more hypotension, more kidney damage in the sense that the kidneys weren't functioning as well. And so there has to be a fine balance in achieving what's an acceptable blood pressure and what could potentially harm the patient.
We talked a little earlier about the Simplicity trial. Before I quite go to that, Dr. Wood, one of the questions is, when's the best time to take blood pressure medicine? And do you want to kind of open up that blood pressure medicine discussion just a little bit? What time of day and where would you start?
Well, there's different ideas about that. There's a certain subset that there's a thought that if you can really control the blood pressure at night, you're going to do a lot better overall if you can really get that nocturnal pressure down. So there's a certain subset of patients, they like to think if you're going to, there's a lot of ways to do this, Ray. One of the big problems with controlling blood pressures is sometimes it takes 2, 3, 4, 5 medications. Compliance is incredibly difficult for a lot of people, for anybody really. They say like 50% of people actually have their blood pressure controlled who actually see a physician or advanced care practitioner. So it's really difficult to control the blood pressure. certain medications, say diuretics, that are going to make you urinate more, you probably want to take those early in the day, in the morning. Certain other blood pressure medications, and it really isn't as important, but in general rule, I'd say it's probably better to take, if you have a once-a-day drug, to take it in the morning if you can. The problem with, as I said, a lot of these drug regimens is they're very, very complicated, which is why often blood pressure is very difficult to control. So in my mind, I think the best, not to make light of this, but the best treatment for blood pressure is a pill that you're actually going to take. So it's important with your physician or whoever you're seeing to have a real dialogue with them. Be honest, saying, hey, I can't take this pill, I don't like how it makes me feel, I'm taking too many medications, I really need to take a little simpler regimen, because there are a lot of different medications out there in different classes. I'd be happy to go into that if you want. But, not yet. But that can, so it's a long answer to a question, but I think it varies.
Leif, what causes high blood pressure? It's one of the questions. This came in from here in Duluth.
There's a variety of reasons. It could just be, old age with the hardening of the arteries. There's poor diet, obesity. There are kind of more pathologic causes, issues with the kidney and endocrine issues that can cause high blood pressure. And so, there's a wide variety of things that can lead to high blood pressure, and you kind of have to tease out what the issue is. For the majority of people, it's called primary hypertension or essential hypertension, which is hardening of the arteries, and there's not necessarily something else pathologic going on with them.
You brought up Dr. Bishu, you brought up the Simplicity trial.
Right.
So do you want to address that just briefly?
So we were discussing this earlier before the show, and so with the Simplicity trial, it was a trial in which patients with resistant hypertension, this is patients with blood pressure that's not controlled despite having 3-4 antihypertensive agents. People are always trying for new ways to treat blood pressure, and when medications fail, what's the next thing to do? So there are a lot of things that are being tried out, but one of the things that came through was renal denervation. The idea is that some of this what we're calling essential hypertension that we don't understand, blood pressure regulation control the brain, the heart, their barosensors, and the kidneys are very strong, and our hormones are very strong regulators of blood pressure. So the thought was that some of the impetus for high blood pressure is driven by signals coming from the kidney. And if we remove that impetus from the kidney by removing the renal, by essentially burning out the kidney nerves, then people will have improved blood pressure. So in this trial, what they did was they randomized patients to either renal denervation, where somebody will put a catheter into the renal artery and essentially burn out using radio frequency signals, burn out the nerves that are lying outside the renal artery. And patients who received that treatment are in the renal denervation arm. And there's another arm of patients who get standard intensive medical therapy, 3-4 antihypertensive agents. So what the trial showed is that the blood pressure reduction was, I think the blood pressure reduction is slightly better in the renal denervation arm, but outcomes, whenever you do trials, whenever you give patient any treatment, you want to look at hardcore indicators, which is, does it make people live longer? Does it prevent stroke? Does it prevent heart attacks? Does it prevent this hardcore measures that hypertension is supposed to worsen, and it didn't achieve those indicators. What the trial showed, however, was that patients who were in the medical arm did have a significant reduction in the blood pressure. And what that tells us, is patients who are in clinical trials are managed a little differently than patients that we see in clinic all the time. You have a nurse coordinator who's calling you, 2-3 times a week, making sure you're taking your medications. They're making you bring your medications to the clinic and counting your pills. So compliance is a lot different from what you see in regular clinical practice. So what that study, the main message we get is that people who take the medications as prescribed, and when compliance is ensured, actually have a really good reduction in blood pressure. So that is really the main message that we have from this.
Leif, any comments on that one?
That was very well said. So yeah, what it showed was that the procedure, the renal denervation, worked, and it did lower blood pressure, but so did taking medications. So while this procedure may have a niche in the future, or with improving technology, it may be something that we're using more and more down the road. Counseling patients about good compliance about taking their medications, and counseling them about the importance of controlling their high blood pressure works well.
John, before we leave this subject, we have to go back. I come to see you. I don't want to take your pills. You're a family doc. Where do we start treating blood pressure?
First, I'd say, Ray, you came to the right guy, okay? We're going to work together, okay? So I'd say it's diet, exercise, because I'd first say, okay, as Leif said, a lot of this it's essential hypertension. It's aging, which we can't control, but diet we can, obesity we can. So you'd start with something probably called a DASH diet, dietary approaches to stop hypertension, working on your salt intake, low-fat diet, a lot of grains. And for some folks, that's a real radical change. But that has been proven to really help reduce your blood pressure. And along with exercise, and I'm not talking running a marathon, Ray, I'm talking about 20 minutes a day, 150 minutes a week of low-impact aerobic exercise. You can talk to your partner you're with. We're not talking about running, like I said, running a marathon or skiing a race. And that's where I would start, and then partner with your physician or advanced care practitioner and get your pressures rechecked in a month or two and see where you're at.
And I would just, in response to one of the other questions, with people with really high blood pressure, I think your family physician is still a good place to start. We're quick to refer to cardiology when we need it. We work together as teams, and we've learned to collaborate. I think we need to go on and talk about coronary disease a little bit and heart attacks. John, as long as I'm picking on you as a family doc, someone comes in, when should people come and see you or come into the emergency room when there's a thought that they might be having a heart attack?
The first thing they want to do is dial 911. You don't get in the car and drive to the ER. I have worked in ERs, and I can tell you that I'm sure my interventional cardiologist would appreciate that. It's nice to be forewarned. You can get the team ready. Ambulances today, they can do an EKG often in the rig. They can take the person where they need to go. So the first thing is to make that call, and the first is to call 911. So you're getting chest pain, you get shortness of breath, palpitations. The difficult part is for females, and it's often very atypical. And
so, guys, when should what kind of things would a female be looking for that's different?
So I think this is a very good point, and one of the things I've realized since moving to Duluth, a lot of times the centers where we can take care of patients who are having heart attacks are limited. There are not a lot of centers, and the population we serve lives in a really wide area, so early recognition is critical in a lot of the patients who have heart attack here, when you're having heart attack here in this area. Now, for chest discomfort, left-sided, left arm, in the neck, in the back. That is unlike anything you've felt before. And if it's coming on without exertion, that is a bad sign. It means you're having a heart attack. If you're having it with exertion, it's angina. It means there's a fixed obstruction, but not necessarily an acute heart attack. The other thing is nausea that goes with this. Abdominal pain, usually on the left side. Back pain on the same side. But usually people, it's not something it's not like anything they felt before. And it's associated with chest discomfort. And a lot of times what people say is that, oh, well, I'm having some dyspepsia. I'm having trouble. I just have gas in my belly, and they take a Tums. And if it doesn't get better with a Tums, that's not gas. So a new symptom.
Pretty much any kind of chest pain.
Any kind of chest discomfort. And it's usually different from what people have felt before. It's unlike anything you've had before.
And Leif, why is that important? What should they be doing, and what's our timeline as we look at this?
As far as seeking medical attention, I mean, if there's a concern that you're having a heart attack, you should seek medical attention as soon as possible, and that's contacting an ambulance to get you to an emergency department to have it checked out. There's a variety of what are called acute coronary syndromes, which run from unstable angina, which is not a heart attack, but it is resting chest pain, and then there are what's called non-ST segment elevation myocardial infarction, or it's a heart attack that doesn't have a specific EKG finding. That does not necessarily, that is still something that needs to be treated soon, but there's not there's not a clock ticking on how soon we need to open the artery up. For a specific type of heart attack called STEMI, or ST segment elevation myocardial infarction, we have 90 minutes from the time they hit the emergency room door to the time we open up the artery with a balloon and stent.
And that's tough from International Falls and some of our faraway places,
You know,
the Upper Peninsula.
I'm actually amazed at the coordination of medical services in this region. Since, like you said, we do serve a very wide area. There are helicopter services, there's obviously ambulance, and the goal from a hospital bringing patients to either Essentia or St. Luke's is between 90 minutes to 120 minutes. And that covers a fairly wide area.
And irreversible damage occurs when?
I mean, it really...
Either one of
well, that's a tough question, because, you know, really when you have a completely occluded blood vessel, heart muscle starts to die within a few minutes. However, so there's not like necessarily a magic number where if you get it done before this time, the heart's fine, and if you get it done after, you're not okay. But that being said, it's a continuum, and so the earlier you open up the vessel, the better the patient does, the less risk of heart failure and permanent heart damage.
It's exactly like, you know, Leif just noted. So that I don't want to discourage people from coming to the ER if it's more than 90. It's absolutely correct. Once you start developing symptoms, we want you to notice different symptoms that could be coming from the heart related to a blocked artery. You need to call the emergency medical services. The studies that have been done so far show that if there's a balance between risk and benefit of trying to open a blocked artery, the ideal time period is 3 hours. So from the time of onset of symptom, if we can get to that artery that's been blocked for less than 3 hours, usually that you can make it without significant damage to the heart muscle. When it gets between 3 and 12 hours, there will be some damage, but still it's better to try to open up that artery. So even though we make a goal, and he's perfectly right, the goal, the criterion is try to, once you hit a medical service, we call it a first area of medical contact. It could be the EMS, it could be an ER, it could be a hospital. We want to get that artery open within 90 minutes.
So John, when you were working ER, and you have, so have I, how did you handle chest pains when they come in? What happens at the local site nowadays?
Well, it's incredibly coordinated, and people take it incredibly seriously. It's pretty scripted. You say the word chest pain, basically the world stops for everything else. That patient is number one. You'll get an EKG right away, and that's going to be probably your first way you're going to start, and you're going to recognize certain findings in the EKG. And if you do see that ST elevation, that pattern, which is pretty easy to recognize in most cases, you'll make a call, and that patient you need to make pretty much immediate arrangements to get transferred. The goal is to have an EKG within 5 minutes, and that sounds like well, you should be able, it's actually sometimes pretty difficult to do that in a pretty crowded ER, but we've got that figured out. And then there's a whole series of drugs you'll give after
They
that.
even get done on the ambulances.
They even get done, and I've had them faxed in or phoned in on an ambulance, you know, so.
Yeah, EMS can actually start
Yeah.
treating before they
Right.
hit the hospital.
Yep.
They're allowed to give aspirin plus other medications, have the EKG done, and call it in essentially and activate the cath lab.
This has been a very interesting evening. We've got a lot of questions that we didn't get to. I would remind you that any chest pain between the belly button and the chin, or the nose actually, and the earlobes that you don't understand, maybe you need to be heading to the emergency room and get checked out. I want to thank our panelists, Dr. Kalkidan Bishu, Dr. Leif Christianson, and Dr. John Wood. and our medical student volunteers, Carter Duncan, Leif Olson, and Sean Staffkey. Please join Dr. Alan Johns next week for a program on infectious disease and immunizations. His panelists will be Dr. Paul Sanford, Dr. Kevin Steffen, and Dr. Harmony Tyner. Thank you so much for watching, and have a great night.